Thank you all so much for having us here today. It's just so wonderful. I mean, we see patients in clinic, but to be able to do these type of events and have some conversations about the disease and what we can do to help the understanding is super important. So I'm going to go through a lot of data. These are updates from ASH, which is the American Society of Hematology. So a lot of this was updates that were presented this year in December. There we go. Here are my disclosures. Okay. So the way that we framed this, Jenny actually helped me frame some of these. Instead of, providing you kind of the name of the study, we framed them into questions, right? So what questions, critical questions, do some of these studies answer that were presented this year at the American Society of Hematology? So I thought this was a very nice abstract. This was presented by my colleague, Dr. Rahul Banerjee at Fred Hutch. And basically what this study asked was, do we still need to do a 24-hour urine test to understand whether the myeloma is responding to treatment or not? So currently, the International Myeloma Working Group essentially specifies that in order for us to best assess disease response, we need to do not only blood testing, perhaps a bone marrow at different times, but we also need to do a 24-hour urine testing. Yes, that's great, but as you all know, that's a difficult test to do, right? You've got to collect urine over 24 hours. You've got to put it in your fridge. You have to bring it to the academic center. It's really not an easy task, and it can be contaminated. So this study is a BMT-CTN, which is the clinical trial network. So it's kind of a big study. There were 645 patients that were included. And essentially they looked at how did the responses look or compare in those who had a urine response versus those who didn't. And really the discordant rate was only about 1%. So being able to assess the myeloma without the urine test actually was just as predictive of like the disease-free period and how well somebody would do. So essentially the conclusion for this study, and I have these boxes, was that perhaps 24-hour urine might not be necessary to restage the myeloma. I think it likely will be necessary in the front line, like when you first get diagnosed, but in subsequent measurements or treatments, generally it's not going to be necessary. And removing it, will only make your life easier, perhaps our life a little bit easier too from a clinical trial standpoint. The International Myeloma Working Group has actually discussed this at a meeting at ASH, and likely this is going to come as a guideline recommendation to remove it very shortly here. So that's actually exciting. Now, Dr. Grajales-Cruz presented a lot of this data in the newly diagnosed. So I'm going to touch on, newly diagnosed, relapse refractory. So I'll give you a flavor of everything and what's new that was presented. So one of these studies, and this is an update from what Dr. Grajales presented, essentially, this new focus that we have is on MRD, which is measurable residual disease. So how do we test MRD? So MRD essentially is obtained when we do a bone marrow, and we look with very sensitive methods, at the millionth level or at 10 to the minus 5, do we see any myeloma cells remaining in the bone marrow? So essentially what this study or what this update at ASH looked at is MRD negativity better when you have 4-drug treatment in the front line, or if you have 3 drugs. So the 4 drugs, as Dr. Grajales mentioned, it was daratumumab or Darzalex in combination with Revlimid, Velcade, and steroid, or having 3 drugs, which is Revlimid, Velcade, and dexamethasone. And essentially, a lot of the studies, we look at survival, but nowadays, as he mentioned, we are looking at this MRD negativity, right? If we see nothing in the bone marrow, how does that predict the outcomes? How does that mean that a patient will do long-term? So this study had a follow-up of nearly, 60 months, right? So a long follow-up. And what we saw is that patients who got 4 drugs instead of 3, you see that the MRD negativity rate was significantly higher. So those patients did significantly better with longer kind of duration of response to the treatment. And then as you see to the right, the progression-free survival, which is basically the period of time without the disease or the disease-free period or remission, as you may, is significantly better, right? So really what that means is that if you got 4 drugs instead of 3 drugs, you had 43% reduction in the likelihood of disease progression or death. So I think that's very powerful. Now, another question that they answered with this new update was, okay, so yes, you might achieve MRD negativity right away, but what about over time, right? So how does that look at 12 months, 24 months, 36 months, 5 years? Is there a difference? Is that MRD negativity, once you achieve it, is it sustained, right? So I think achieving it is one thing, sustaining it, ideally, that's even better. So essentially what we saw, to the left, on the right is the 4 drugs, to the right is the 3 drugs. And what you see is, first, the level of MRD negativity is significantly higher with the 4 drugs compared with the 3 drugs to the right. And it is really sustained over time at that 5-year period up to 61%, which is really quite impressive and encouraging. So adding Darzalex to the Revlimid, Velcade, and dexamethasone, you see they're almost doubled, right? That 12, 36, and 5-year sustained MRD negativity, which in the end, it does translate into what we call progression-free survival. And quite frankly, I suspect there will be an overall survival benefit with this as well. It's just that, data is new and we need more time to develop these concepts. And then the way that you can look at the bone marrow, you can look at it, the pathologist looks at your bone marrow with their eyes, right? And they say, well, we don't see any myeloma cells, but with the MRD, like I said, more sensitive testing, and you could do it at a level of 10 to the -5 or 10 to the -6, which is even the most sensitive test we have. So essentially what we're seeing is at any level, 4 drugs are better than 3 drugs. And that is sustained. The data looks incredible. So as my colleague mentioned, generally, if you're able to get 4 drugs, work with your doctors, that's going to be for the best in the newly diagnosed setting. So we see, significant survival benefit. And this is really summarizing what we talked about. The name of the study is Cepheus, and there's been multiple studies that my colleagues went over. This was just an update in how long we maintain that MRD negativity. The other study that my colleague talked about as well, this was also updated in the MRD Sense at ASH this year. So this is IMROZ. So basically with this study, it's again another 4 drugs versus 3 drugs in the newly diagnosed setting, where you have Cevostamab with Velcade, Revlimid, and dexamethasone. So Cevostamab and daratumumab, very similar drugs, CD38 monoclonal antibodies. And then you compare it to Velcade, Revlimid, dexamethasone. And essentially, what we are looking here is this MRD negativity, this measurable residual disease. Here again, we see that looks significantly better with 4 drugs compared to 3 drugs, and that translates into disease-free periods or treatment-free period, if you may. Now, again, the question is sustained MRD negativity, right? So it's not achieving it, it's maintaining it, sustaining it, so you can stay in good disease control over time. And you see in purple, you have 4 drugs, in green, 3 drugs. Clearly the 4-drug maintenance of that measurable residual disease negativity significantly higher. You see that these rates, are 2 to 3 times higher. So in theory, 4 drugs, always better than 3 drugs. If somebody is able to tolerate it. Anytime you have achievement, sustainment of MRD negativity, that will translate into survival benefit, like progression-free survival. And then this is just the summary of what we talked about. Now, on top of these, drugs that we've mentioned, right, the Darzalex and the Cevostamab and the other combinations, we have what are known as bispecific antibodies. So this is a type of immunotherapy, and we're going to talk about this a little bit later in the session, but these generally target the myeloma cell and a component of the T cell. So one of these bispecific antibodies is called Teclistamab. So Teclistamab targets what is known as the BCMA, which is basically a protein or a molecule that is found on the myeloma cells. And currently, this Teclistamab is approved in late relapse. But the question is, what if we bring these novel drugs, these new immunotherapies as frontline treatments, right? How will that look? Does that work? So I know this is pretty complicated, so I'll try to kind of simplify it, but really what the study looked at was using Teclistamab, so using this bispecific antibody in combination with some of the other drugs that we commonly use in different regimens, where you might have gotten it weekly, you might have gotten it every 4 weeks, and it was in combination with Darzalex and Revlimid, or Darzalex, Revlimid, and Velcade. This is pretty novel, right? We've never seen this done before. So patients got a Teclistamab combination for induction, like for frontline treatment, and then you got a transplant. And then after the transplant, generally maintenance treatment has always been kind of Revlimid, right? So now we also adding Teclistamab as maintenance to the Revlimid. So pretty complicated schema. The name of the study is Majestic 5. So this was first presented at ASH this year. And as you see there, the number of patients that are treated is small, right? You see the numbers range anywhere from 5 to 10 patients per each of those arms. But what we are seeing is that the response rate is ranging anywhere from 90 to 100%, right? So patients treated with this combination nearly everybody had a response, which was really quite impressive. But anytime you have a treatment that works really well, you have to think about, well, is it going to have a lot of side effects, right? So some of the things that, we looked at in terms of safety is hematologic toxicity. What does that mean? Low blood counts, right? So you have to continuously monitor the blood counts. With these bispecific antibodies, Dr. Coffey will go over this, you have what's called CRS, which is cytokine release syndrome, which the best way I feel like I can describe that is like having the flu, kind of like a virus with high-grade fever. That happened, but it was low-grade and manageable. Infections can occur with this type of treatment. And one other big question was, well, if we use this new treatment up front, are we going to be able to collect enough cells for transplant? And we were able to. There was no problems with collecting enough cells and being able to get a transplant with this. And really what was also very exciting, I think, for this study is that everybody that got treated with this regimen got into MRD negativity. Everybody got into where they couldn't see myeloma cells in the bone marrow, which I think was pretty impressive. So this is kind of like a first of its kind, first study that combined Teclistamab, which is this new immunotherapy, with frontline drugs. And it really showed very impressive kind of efficacy responses. Certainly there are some side effects that we have to consider and think about, but MRD negativity was achieved in everyone, and stem cell transplantation and collection of those cells did not appear to be a problem. So what about maintenance chemotherapy, right? So as we know, and probably a lot of you know, is that generally after a transplant, the treatment that we get, what we want to do is we want to maintain that response, right? Once you get a good response, you want to keep that response going so the disease is under good control for a long period of time. So standard of care has always been low-dose Revlimid. Nowadays, we're really changing that, where we're combining, depending on the risk that someone has. If somebody is higher risk, we might give, 2 drugs or, a variety of drugs to kind of try to keep the disease in good control over a long period of time. Well, this study is called the Auriga study. So this study says, for patients with newly diagnosed myeloma, after transplant, is Revlimid alone better as maintenance, or is a combination of Revlimid and Daratumumab better for maintenance therapy? So I think this is actually a very nice study that likely will change and is already changing practice. So essentially here, the only caveat is that patients, when the study was first started, did not receive Daratumumab in the original treatment. But you see, some patients got Daratumumab with Revlimid and some got Revlimid at 10 milligrams as you normally would. And we looked at outcomes in different patient populations. So essentially what this table shows is this, this word MRD keeps coming up and up and up. So 12-month MRD negativity, right? Conversion from positive to negative. You see that in all patients, all of them benefited from getting 2 drugs for maintenance instead of 1, the Darzalex with Revlimid compared to Revlimid alone. So essentially what we saw is that having these 2 drugs, Darzalex with Revlimid compared to Revlimid alone as maintenance, it was helpful for everyone, regardless of how old you were, regardless of age, race, sex, disease stage. So, I mean, this was really even beneficial in those who had not only standard risk disease, but also high risk disease. So I really think this will shift or change the paradigm in how we manage maintenance treatment. And really what we saw is that even some patients with high risk disease based on modified criteria did benefit from doublet maintenance compared to maintenance with one drug alone. And this is, again, summary. I like to do these summaries, but essentially what this study showed, or what the conclusion is, if you add Darzalex to Revlimid as maintenance after transplant, that is going to improve the MRD negativity. It's going to lead to a favorable disease-free period. And there was really, from a safety standpoint, I didn't really show this, but there was no really increased safety signals, no new side effects other than, what we would expect with these treatments. So that was not a concern for the study. So relapse multiple myeloma. So a lot of my practice is focused on relapse multiple myeloma. I should have introduced myself like my colleague did, so apologies. I work in the bone marrow transplant and cellular immunotherapy at the Moffitt. So I am actually a transplanter by trade, and I do CAR T cell therapy. So I treat a lot of patients with CAR T at Moffitt. So relapse myeloma is very close to my heart and a lot of what I do. So I'm very excited to talk to you about this and what's coming down the pipeline, because the field, in my opinion, has never looked so bright. So again, MRD negativity. My colleague, Dr. Castaneda, will talk a little bit later about CAR T cell therapy, what it is, how it works. I just want to point out before I go through the study that we have 2 FDA-approved CAR T cell products. One of them is idecaptogene viclucil. This is a big word, a lot of letters there. Abecma, it might be the name you might have heard. The other CAR T cell therapy is called ciltacabtagene autoleucel, or Carvykti. So I'm going to go with Abecma and Carvykti. Both are FDA approved, and they're approved kind of as soon as second and third line, so not in the front line yet. So this study here looked at Carvykti. And this is known as CARTITUDE-4 because what this study compared was Carvykti, so CAR T, versus combination chemotherapy agents. And essentially we looked at if you got CAR T versus if you got a chemotherapy combination, how were the outcomes? Were they any different? Which patients did better, right? So here in red, the bar graph in red showed patients that got CAR T or Carvykti, and the black one shows chemotherapy. And the bar graph differences are showing the difference in MRD negativity, right? So measurable residual disease. And essentially what we saw is that in patients receiving cilta-cel or Carvykti, they had significant improvement in MRD negativity. So significant ability, right, to achieve or get into that complete remission state compared to those who receive chemotherapy, as you see there. And all patients benefited across nearly all subgroups, regardless of age, race, high-risk disease. So this treatment has really been kind of impressive, transformative in the treatment of our patients. Now, and I keep harping on this, right? Yes, these patients who got CAR T did a lot better than those who got chemotherapy and achieved MRD negativity, but were they able to sustain it, to maintain it for a long period of time? I think that is crucial. And what you see here is that they were sustained MRD negativity. You see there to the left at 12 months or more, significantly better, right? You see the 52% versus 10% with CAR T versus chemotherapy. So I think CAR T blew chemotherapy out of the water, for lack of better words. Anytime you have MRD negativity and you sustain it again and again, you're going to see improvement in disease-free period and in overall survival, the amount of time that somebody lives. And this study is really the only one that has shown that and is quite impressive. And this is a summary. So essentially, cilta-cel or Carvykti significantly increased this MRD negativity rate, which then in the end turned into sustaining that response and achieving survival benefit, which is super important. That's why we're doing these trials, and we want you guys to live long and have a good quality of life. Now, this study is a study that we ran with some of my colleagues where we said, okay, well, we have two CAR-Ts. We have Abecma, we have Carvykti. Which one should we offer our patients, right? Because they're slightly different, but we don't have any studies. We don't have any evidence that says one is better than the other. And I think it's informative to be able to see, is there any differences from a safety perspective? Is there any differences from an efficacy perspective? So this was a large cohort of patients where we said, okay, we had 641 patients who got collected for a CAR-T. Of those, over 500 got infused. And essentially we compared, right? Did Carvykti do better than Abecma? And essentially this is a complicated table, but I'll explain it. Essentially what this table shows is that patients who got Carvykti did better. They had better responses, they had better depth of responses, but they had a higher incidence of certain toxicities. And what were those? So slightly higher high-grade cytokine release syndrome, or that flu-like syndrome. There were more infections, and there were more of what we called the delayed neurologic toxicities that we see, and Dr. Castaneda will go over some of that. And certainly we have mitigation strategies for these, and he will discuss that as well. You know, but a lot of times at the end of the day, we want to know, right, if we go through all of this treatment, this is a tough treatment, it's very complicated, you know, how long am I going to live, right? Is this going to make a difference long term? And surely it is, because if you look at these curves, these are impressive. In blue is Carvykti, in red is Abecma. So what we're seeing is significant improvement in outcomes, the disease-free period, and even survival long-term with Carvykti, which I think is super important. So here again, this study compared two products. It did show us one works better, but it does have more side effects. And hopefully, I think really the point here is to help, you know, when we see you in clinic, is to help educate you, right? One might show the side effects, one might work better. What do we think might be the best answer? Now, you know, so you've had Carvykti perhaps, you might have had Abecma. What's next, right? Let's say the disease might come back. I hope it doesn't. But if it does, we have options, and we have really good options. So one of them, this is a new CAR-T that targets a different area on the myeloma cell than the Carvykti or the Abecma. So this is called arlocaptogene autoleucel, Arlocel for short. This targets a different protein on the myeloma cell called GPRC5D. It's the same target as Teclistamab. If any of you might have received that, is a bispecific antibody that again targets the same. And here with this new, I don't know what happened. Okay, with this new CAR-T, essentially we gave it to patients after relapse, after they might have received a prior BCMA, but we also gave it to patient earlier in the disease course, so there were two different cohorts. And really, these are the results, and they're quite impressive. So really what we saw is that about 50% of the patients had received a prior CAR-T. There were some infections, and with this new GPRC5D, there can be some toxicity of like nails and skin rashes, and sometimes it affects your taste. But thankfully, all of those were grade 1, and they kind of spontaneously resolved, which is exciting. And the response rate, even if you've had a prior CAR-T, was quite good. It was 87%. And then the patients who got the actual recommended dose, it was 91%. And nearly everybody seemed to benefit, which is really quite impressive. Now we have to think about long-term some other toxicities like what's called cerebellar toxicity. But nonetheless, you know, for those folks who have had a lot of treatments and might not have any other good treatment option, this is quite impressive results. Sorry, I'm having trouble with, here we go. If you look at the survival, I mean, look at the progression-free and overall survival, where otherwise it might have been, let's say 4 to 6 months, you're seeing their 12-month, 90% of the patients are alive and likely in remission with this treatment. So this is quite impressive, and it is going to be a treatment that likely will come in the next few years in patients who might have had a prior BCMA CAR T. So again, as a conclusion, this is a first-in-class new CAR T that targets a different area on the myeloma cells than what is currently available. From a safety standpoint, acceptable risk compared to what is available, and the efficacy or the outcomes are quite impressive, over 90% responses, and the survival looks quite good. So very excited about this product. Another CAR T that's coming down the pipeline and likely will get FDA approved next year, 2026 is the expectation, is something called anito-cel or anito-captogene autoleucel. So how is this different from what's available, right? This is another CAR T that targets the same area on the myeloma cell that what is already available, the Carvykti and the Abecma. The only difference in this CAR, and I'll do my best to explain, is that it's got a small protein, and that small protein kind of attacks the myeloma cell and comes off really quickly. So in theory, because it comes off quickly, it might not cause as much toxicity or as many side effects. Hard to say because it's still early, but overall, these patients that were treated, were treated for prior lines of therapy. They had high-risk disease. In terms of this flu-like syndrome or the CRS, majority was grade 1, and there was not a lot of neurologic toxicities, which was very encouraging. But what we're excited about with this product is that with Carvykti, for example, you might see what you might have heard as like Bell's palsy or even, very low rate of Parkinson's. With this product, so far, the follow-up is short, 10 months. They have not seen any of these neurologic toxicities such as Parkinson's or Bell's palsy. So again, this is very exciting. Response rates with this product, 97%. So 97% of patients who got the product got a response, and about 62% got into a complete remission, which is impressive. And this will translate into survival benefit. And this is just the summary, just some of the same things we discussed. This is a new CAR T. It is coming down the pipeline. It looks very good efficacy and safety-wise, so very exciting. Now the question is, and I think we'll have to find out the answer, right? So if you've had a prior CAR T, let's say you've had Carvykti, can you get anito-cel? I don't know the answer to that. We need to study it, and we'll see how it works out administrationally wise in terms of, policy of will that be allowed or not. But certainly it's a very fascinating question. Now, very complicated slide, but the question is, we have multiple bispecific antibodies and CAR Ts that we just talked about that are FDA approved, and they target 2 proteins. One is called BCMA, the other one is called GPRC5D, but we need more than just 2, right? Because yes, this is incurable, but it's very much treatable. There's a lot of things coming down the pipeline, as you see, and I should have mentioned this. With CARTITUDE-4, which is that Carvykti, there's going to be some new data presented at ASCO in about a month. And it's going to show that maybe there will be a functional cure for some patients. But that data is coming. Very excited for you guys to see it as it comes out. Anyway, shifting gears, Cevostamab. So this is a new bispecific antibody. It targets a different area on the myeloma cell called FcRH5. Very exciting because it's a new target. Interestingly, the patients that were treated at this dose level, majority of them had received a prior BCMA product before, like a BCMA CAR T. And what's exciting is that even in somebody who's had a lot of treatment, this works. The response rate in those who hadn't had a prior CAR T was as high as 61%. It's quite impressive, especially for patients who got a response. That response tended to be long-lived, which is exciting. And it just opens the door, right? Because a lot of times we might not just use a drug by itself. We might have to combine it with other things to get more benefit. But nonetheless, the concept here is great. This is a new target. Toxicity is as expected. Response looks good. And it just highlights the potential that we might have something new to target down the road for myeloma. I'm almost there, I promise. A few more slides. This is Belantamab, mafodotin. I don't know if some of you might have had this in the past. It was in the market, then it came off, but it's making a comeback. This is a comeback kid. This is a study that looked at Belantamab in combination with Velcade and steroid versus daratumumab, Velcade, and steroid. And essentially what we saw is that those who got the Belantamab combination, which is called the DREAM 7 study, I'm only presenting DREAM 7, there's multiple DREAMs, but this is the DREAM we'll discuss today. The response rate was higher for the Belantamab combination. The issue with this drug, I think a little bit, is some patients might have blurry vision, so it's kind of visual side effects where we might have to see an ophthalmologist or an optometrist as we get this treatment. And I think what they've done with this study is nice because the frequency of giving this drug has been less, which hopefully will mitigate some of those side effects, but clear benefit in terms of survival or disease-free period with this therapy. Here is a summary for you guys, but basically what we're saying is the Belantamab or Belamaf combinations are showing good responses and benefit. So last but not least, we have, there's all these therapies, particularly for CAR T. Is there something that can tell us, am I at high risk to develop toxicity? Am I at high risk not to get as good of a response? And if so, can we do something about that? So this, again, slide complicated, but there is. So this data was presented at ASH. There's a very simple calculator called the CAR Hematotox. And it accounts for certain features. So it looks at your blood counts, and it looks at your inflammation markers. And generally, if the score is high, you're more likely to develop toxicities, and actually turned out you're less likely to get a response. So how does this help us? It shows us that those who have a high score might not do as well. And then there's some other factors that might help improve this model. But really, as a summary, essentially this score helps us identify who's at high risk to have a safety event, who's at high risk not to do as well. And then we can come up with mitigation strategies during that period to support you guys with anti-inflammatory drugs and myeloma drugs. This is the last abstract, but basically the question here is, we have CAR Ts, we have bispecifics. Can I benefit from a bispecific if I got a CAR T? You can, actually. And this is a study where we looked at if somebody had received, let's say, a prior CAR T, could they benefit from Teclistamab? Yeah, they can. The response rate is 51%. That's impressive. You need a washout period, but you still can benefit from that treatment. So I think that's really the main message here. So yes, if you've had a prior BCMA, the response might be lower, but you can still benefit, and it's still a very good and viable treatment option. So this is just a summary of some of these slides that I presented today, but essentially there likely is going to be de-emphasis of the 24-hour urine protein down the road, hopefully coming soon. As my colleague Dr. Grajales-Cruz pointed out, quadruplet regimens are better generally from an efficacy standpoint. And then we have lots of ongoing clinical trials looking at maintenance and lots of new immunotherapy trials in the horizon, including others that I didn't mention, like dual targeted CAR T, trispecifics, cell mods. I had to remove those slides because I didn't have enough time, but happy to talk more at the small group sessions. Thank you all.